Hey everybody, welcome back to the ECG channel. My name is Reed, and before we get started, don't forget that you can download this PDF down in the description below, and you can follow along and make your own notes, save it for later for your studying, and don't forget to subscribe to the channel and like this video if you enjoy this content. So let's get started. So first thing I like to do is look at the forest, and the trees of the forest are my QRS complex. So maybe down here in V5, this is a rhythm strip. We see we've got a narrow complex rhythm that's going pretty quick, and then you see the rhythm kind of changes. It gets a little slower, and then fast, slow, fast, kind of in the middle here. It starts to kind of regularize, kind of, and then it gets fast again, right? So as you kind of scan through the entirety of the rhythm, I get the sense that this is pretty irregular, okay? And so we've got an irregular rhythm, and I look to see, well, why is it irregular? Is it because we've got a second degree AV block? Do we have sinus pauses? Do we have a sinus node exit block? Do we have AFib? So I just kind of get an idea of why, and I'm looking for P waves. I don't see any distinct P waves kind of before my QRS complexes. I don't really see them anywhere, right? If I scan throughout, I see this baseline kind of fibrillatory pattern. I think I might have just given it away. So in the setting of a irregular narrow complex rhythm, that is no pattern to the irregularity. So this we would call this irregularly irregular, right? It's not like we have like beat, beat, drop, beat, beat, drop. Then that is really telling us that in the setting of a narrow complex rhythm, this is atrial fibrillation, right? And remember that AFib is a disease where the atria has a bunch of these reentry pathways, and so you've got these fibrillatory waves that are running around, and they bump into the AV node. They bump into the AV node, and the AV node then transmits that signal down in the normal fashion through the QRS. That's the baseline for this patient. So the AV node, we see the AV node is a bystander, right? And so to determine the ventricular response, it has to do with how often the AV node decides to pass that signal down. And so we have to determine the rate in that sense. But because AFib is so irregular, we can't just measure the rate between this QRS and this QRS, because that wouldn't give us an accurate representation, because look at it over here, it's a lot different. So what I like to do is, I know that this is a 10-second strip, and if I count all the QRSs and multiply it by 6, I get the total beats per minute, right? So I have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. So I have 17 beats in this 10-second strip. So if I multiply that by 6, then I get 102 beats per minute. So we've got a tachycardia. And so we have atrial fibrillation with a rapid ventricular response, right? And so that just tells me that the ventricles are beating at a rate of over 100 in the setting of AFib, right? We need to classify that. We see AFib with RVR is oftentimes kind of caused by something that causes your body to be in this hyperadrenergic state. You're secreting a lot of hormones that are excited, right? Your body is fighting. And so we always want to investigate that, and there are ways to investigate that in the ECG. So we've gone through a few of our rhythm. Let's take a look at the QRS itself. We see that it is narrow. If I look at the duration here, it is less than my QRS, is less than 120 milliseconds. That's good. Let's look at my QRS axis. It's upright in lead 1. It's down going in AVF. So that tells me that it's going away from AVF but towards lead 1. And this is negative in lead 2. It's even going away from lead 2 as well. So it's somewhere kind of up in this area. So that is left axis deviation. We have certain causes for left axis deviation that we'll kind of look for here. Let's take a look at our QT interval just briefly. You can look in between like R to R's. You can see this T wave here. The T waves are pretty contained, right? They definitely end between the halfway mark of most of these R to R intervals. So that's good for our QT interval. And now we're going to kind of look for these QRS morphology, and at the same time we'll kind of look through these pathological Q waves and ST and T wave changes. And so first thing we're going to notice is that we have left axis deviation, and we've got poor R wave progression, right? We've lost our septal R wave. So you wonder if this is more of a kind of a pathological Q wave, maybe a septal Q wave, or maybe this person had a previous septal myocardial infarction under the V1 and somewhat V2 is more of our septal leads. And what you'll also notice here is in the inferior leads 3 and AVF, more specifically, if this is our baseline, look at this ST elevation. And same thing in AVF, baseline ST elevation. So we have ST segment elevation in the inferior leads, which in this case more of lead 3 and AVF, so more of our right-sided inferior leads versus lead 2, a little bit in lead 2, but less so. We've also had the development of these pathological Q waves in the inferior leads. Look at those deep Q waves, right? Look at those deep Q waves. That tells me that this infarction is progressing, right? So we've got these pathological Q waves in the inferior leads that tell us that maybe some of this myocardium was already infarcted, right? And then we have a little bit of ST depression here in V2, a little bit of ST depression in lead 2. Remember that ST depression in lead 2 can actually tell us that, if lead 2 is right here, V2, if we have ST depression, it can actually tell us if there is infarction to the posterior, right? It's kind of a reciprocal change for the posterior myocardium. So we actually might have not only inferior infarction with the ST elevation in the inferior leads, but we also might have some posterior involvement, okay? Posterior, okay? Notice that we've also got reciprocal ST segment depression in leads AVL. Right, here's our baseline. Here's our ST depression. And lead 1, baseline ST depression. That is reciprocal depression, right? Imagine if we have ST segment elevation here in leads 3 and AVF, well, what are our ST segments going to be in the leads that are kind of opposing that? Well, they're going to be reciprocally depressed. And so that really helps define the fact that this is real ischemia. And so let's put this all together, and what do we have? Well, we've got an atrial fibrillation with a rapid ventricular response at 102 beats per minute. We've got left axis deviation that is best explained by this inferior ST segment elevation, which appears to be progressing in the sense that there are pathological Q waves. We've also got ST depression in lead V2, which suggests posterior extension of that inferior MI. And we've got reciprocal ST segment depression in our lateral leads 1 and AVL. And so this person is having a ST segment elevation myocardial infarction, likely driving some of this AFib with RVR, right? Their body is fighting, and so their body is in this hyperadrenergic state trying to stay alive. And so we also could see kind of the increased likelihood of them going into a rhythm like AFib with RVR, right? So I hope this video helps you all. If you have any questions about it, feel free to drop a comment down below, or just if you want to comment in general and say hi. But otherwise, like this video if you do enjoy this content. Feel free to subscribe to the channel. Thank you so much for watching, and we'll see you on the next ECG. Have a great day.